Welcome to the first cup of Joe. And you'll have to pardon that pun, but I figure with a name like Joe, we might as well have this. It's a series of Facebook Live conversations on topics that are among the most important to constituents of the Hampshire, Franklin, Worcester district. We launched this series, and here I want to shout out and thank the fabulous work of Caitlin Billings, who directs communications and engagement for our team. We launched it to open up a new way for our team to get timely information to you, to the people we work for. And I can think of no one better and few topics more pressing than healthcare, especially now with the turbulence at the federal level. So if you want to talk healthcare in the legislature, you talk to Senator Cindy Friedman, who has very generously offered to kick off our series. So our conversation today will last until just before 12:30, when I'll close and talk about next steps. Senator Friedman is the Senate chair of the Committee on Healthcare Finance. She is also vice chair of Senate Ways and Means, and she happens to be one of my very favorite people. Senator Friedman is a true force of nature with a huge heart and an even bigger brain, an even bigger determination. She's a teacher and a close collaborator of mine, who, in addition to leading healthcare work for the Senate, dedicates herself to protecting issues we all care about, right? Like reproductive freedom, gender affirming care, and much more. Welcome to you, Senator Friedman.
Thank you, Senator Comerford, and I'm glad to be part of this mutual appreciation group. I am so happy to be a colleague of yours. Your constituents should know how amazing, how clear-headed, how determined you are, and what an absolute pleasure it is for me to be able to work with you.
I'm schwitzing.
You are so much part of that brain and heart that we need more of today.
Today we need more of it, indeed. Well, thank you. Thank you. And it is really good to talk to you about healthcare. I'm telling you, in my district, as you know, and I'm sure the truth is in your district, education, healthcare, the environment, they rank right up there. So last session, you led the work in passing what we call in the Senate the PACT Act. The Senate had passed this before, you passed it again, and that focused on pharmaceutical access, cost, and transparency. And you led the work in the Senate to pass healthcare market oversight legislation. So for folks who were tracking this all along the way, we're talking about two bills: an act enhancing the market review process and an act relative to pharmaceutical access, cost, and transparency. So if it's okay with you, Senator, I'd love to start with the market oversight process and the role of private equity. We didn't have a Stewart Hospital in Western Mass, but as you know, our hospitals struggle, and just today, Bay State's announcing more layoffs. So the concerns about hospitals and the financial stability of hospitals are real. Can you talk to us a little bit about what the law around market oversight does and what kind of impact you hope it has?
Happy to. So the bill that we passed basically sets the groundwork for the state to be able to better oversee and control the role of for-profit in the healthcare system. So as you know, Joe, because you've been really involved in this, Stewart Healthcare had 7 hospitals. They pulled out. Turns out they were very much embedded with private equity. Private equity is a model of business which takes a group of investors' money, not their own, but they find a group of investors. They find in this case, they found what they thought was a good buy. They buy the entity. In this case, they bought the hospitals. They sold off all of the assets, including the buildings, took a loan, but put the loan back onto the hospital systems. So the hospital systems were responsible for paying the rent and paying, the mortgages, paying the rents, et cetera. And the model of private equity is to get in, buy something, do whatever they need to do to increase the value to the investors, and then get out quickly. So 2 to 5 years is, versus venture capital, where venture capitalists take their own money, they invest it into something that they believe can grow, and they're in it. It's a much longer term investment. And at the end, usually the end of that investment becomes when something goes public. Well, in order to go public, it has to be pretty, sustainable. It has to meet all these requirements. And the folks putting their money in, it's their money. So they're vested in this being successful. That's not what happens with private equity. So private equity is now a huge part of healthcare. They buy lots of clinics like, autism clinics and physical therapists and dermatologists. And then they put their own people into those organizations, and they run it for a profit. And once they feel like they've gotten as much as they can get out, they get out. And it sort of doesn't matter how they leave it. They're not interested in how they leave it. They're just interested in how much money that they can make out of a short-term investment. So this bill is trying to set a framework, and the framework is we are now going to gather information about private equity firms that come into the Commonwealth to do business in the delivery of healthcare. We're going to require that there be a very in-depth amount of information, so that, and then we're going to also, the bill also says we need to know every single healthcare entity that does business in Massachusetts, so we know where the private equity is and where it isn't. We're tracking that. We're requiring them to be part of the information that we gather, so that we can take the next step, which is to really control it, which is to say, hey, if you're a healthcare entity, you can't acquire more than 10% debt or some percentage, so that you stay stable. Okay, so private equity can't come in and load 80% of the debt on you. We're doing other things. So private equity, for instance, in the next step, what we want, given that we now have this information, and some of that information is who are you and who owns you, because private equity it's a bit of a Ponzi scheme sometimes, right? They continue to open up subsidiaries, so you really don't know who's buying you. We were now requiring all that information. So I see it as a very basic but incredibly important step in order to control that healthcare. That's the really high level of it. And it goes into much more detail, but that's basically that's the fundamental part of what it's doing.
So thank you so much for that overview. I know that I had constituents who felt really blindsided by the Stewart crisis. They had family members where there was a Stewart hospital, and they wrote to me and they said, I had no idea who owned Hospital X, and then how can they just leave? And you're saying to us that, in fact, that's the whole structure of private equity. They can leave whenever they want, and their job is to maximize profit.
Right.
And when we have the job being maximizing profit, it really collides with the provision of quality, accessible, affordable healthcare.
Right. There's no Venn diagram where those two pieces, where the delivery of healthcare and the private equity acquisition come together. There's not. Yeah. It also makes all of these companies part of the Health Policy Commission cost trends hearing. So they have to show up and they have to testify in front of and to explain why their pieces of this are growing and how much they're growing in the cost to the Commonwealth, to the residents of the Commonwealth. So there's all other parts of, if you come for a license, you have to give much more information. But you've hit the big points.
Well, you've hit the big points, actually. And thank you. And I think, sometimes when we pass legislation, it's hard to see the immediate impact But just what you said, for example, is pretty seismic, right? That the Health Policy Commission will now hear testimony and it's required. So there can't be, besides tracking private equity investments, there has to be a public accounting of this with good folks asking good questions. So I think that's exceedingly important.
Right.
Um,
And, we have, the Senate bill, as we passed it, had a much, much more oversight, control, requirements for reporting. This is what we could come to consensus with, given the time that we had, but we're pressing on. We're ready to do the next round in the
yeah,
Senate.
yeah, I totally understand that. I think everybody watching is going to understand that, right? That it's a big enough chunk. And thanks to, to you for continuing in the Senate and continuing to lead, we'll do the next chunk. And my constituents will, I'm sure, be happy to hold me accountable for continuing that work.
Right.
So let's switch now to prescription drug control, cost control. So this has been your baby for a really long time.
Yes.
When I got into the Senate, you were talking about this. Talk to us about the PACT Act, Senator. And again, whereas the private equity may be hard for our folks to, fully see in the immediate terms how it's going to help them, but of course it's going to help them. The PACT Act comes right home to our family budget.
Sure. So before we passed this bill, the state was very good at overseeing healthcare costs, and they watched the trends in healthcare costs go up, but they only looked at hospitals and physician organizations like that and insurance. So it was basically insurance and hospitals. Who was left out of this was pharmaceuticals and pharmaceutical benefit managers, who are the middlemen between an insurer and a pharmaceutical company. And the middleman is who buys the drug, who contracts for the drugs, negotiates the prices, does the rebates. And they, if you think of your insurance company, they take all of their pharmaceutical stuff, carve it out, and give it to the pharmacy benefit manager to manage. So up until this point, we had no information control or visibility into what was going on. And pharmaceutical costs are the largest growing costs in our healthcare system. So what we have done now is we have made pharmaceutical industries and pharmacy benefit managers part of the cost trends hearing. So they are now part of what the state looks at and they are now held within the framework of how much costs can grow. So right now, costs, we set a target, it's 3.6% increases in overall healthcare spend. And pharmaceuticals are now part of that calculation. This is a big deal. It's a big deal for the Commonwealth. And I'll talk about that in a minute. The second thing that we've done is we now require that insulin, asthma, and all insulin medication, asthma, the most important asthma medication, and 2 chronic health medications be capped at, for brand names, $25, and for generics, $0 copays. So that means that those will no longer be, if it's a generic, there's no copay. If it's a brand name, it caps at $25. So this is going to affect, we looked at about 180,000 people in the Commonwealth. Now, do we want to do more? Absolutely. Do we want to make sure that we include all the delivery devices? Because insulin and asthma are very much dependent on how they're delivered. So there's the medication, there's delivery. Very much want to do that, and we're gonna push to see that. And then what we'd like to, so that's what this does right now, brings them under the purview of the state for tracking. It also requires that pharmacy benefit managers be licensed by the Division of Insurance. Right now, they don't need to be licensed. They can do whatever they want. Same with urgent care centers. Like Quick MD and those kinds of, they don't have to be licensed. Well, now we're saying you all have to be licensed in order to do that.
And just an aside, we talk a lot in Western Massachusetts about the rapid healthcare providers here. We're going to talk about primary care if we have time at the end. But they often say, "Well, come to us, right? You can't find a primary care doctor here, but we're
Right.
here." And now some are held in places like Cooley Dickinson, MGB's Cooley Dickinson, and
They
that
own those.
yeah,
They're licensed, right?
right. But then some of them are folks who've set up shop. And
Right.
so I want to make sure that constituents understand that that was part of, it's a pretty seismic change inside an overall cost access control bill. So sorry,
Right.
Senator.
No, that's really important because there is no requirement basically outside of some very basic DPH requirements like the size of the rooms and et cetera. But there's no licensing of, and how do they deal with insurance and, what kind of care can they give and how are they, do they meet all the sort of the real important healthcare requirements? When you go, does your insurance cover it? Does it not? Should it, So all of those pieces, so now we're going to license those folks. And that's also, I think, really key. So again, this is the beginning of being able to really address the pharmaceutical costs. Now, part of our challenge is that pharmaceutical companies and the pharmaceutical industry is like, besides hospitals, is the huge economic driver of the Commonwealth of Massachusetts. And so I apologize for the sound. Can you hear that? Okay, good.
You're nothing but you.
Okay.
Happy.
And so people are worried when we start to oversee or regulate in any way this industry. And I'm very cognizant of that, and I appreciate the concern. I think we have a long way to go before what we do would actually affect the bottom line of a company. So I think we can do a lot and still maintain a really healthy, robust system in the Commonwealth for, developing drugs. And again, this is around delivery. It's about giving people medication. It's not about the research. It's not about requiring anybody to do anything different. But at some point, you have to look at the cost because nobody's going to be able to afford it. The new non-opiate medication that just came out for substance use disorder, addressing substance use disorder, is $31 a pill a day. I mean, it's great. And if it works, it's wonderful. But how many people are going to be able to afford that? So we have to really, these two things, we have to hold them both together and figure out the best way forward.
I want to just pick up on two things that you just said. One is the the ways in which the legislature has to consider the overall Commonwealth when making decisions. This was a big transition for me. As many folks know, I was an organizer before coming into the legislature, and I saw things as an organizer sees things, pretty one-dimensional. And that was my job. My job was to make that case about that one issue and pound on government, right, to hear me. But people in government have to think of the biotech industry or the pharmaceutical industry, not only because our constituents have jobs in that industry, they may locate businesses in our districts that are important taxpayers, but also because of the overall well-being of the Commonwealth, right? We want to be a destination for these companies because these are good jobs, high taxes, a growing industry, which is the last point. And the second thing I want to just point out in what you just said, Senator, is that your PACT Act is almost a sister to the opioid prevention bill that also passed and was signed into law, right? And this is about, and so not every bill can do everything.
Right.
And yet, so while you're working on that cost control and access and containment, you were also working with lots of other good people, to advance, and the Senate President, of course, and the Chair of Ways and Means to advance that opioid related bill. And they need each other, right? And that's another part of the
Absolutely.
legislature that we have to keep an eye on, right? Constituents should know that we're keeping an eye on, you know, we have to make sure this medication will get to you in ways you can afford it and access it, and in delivery mechanisms that work for you. And then we have to do all of the barrier breaking, and advancing things like non-opioid pain medication, which is, you know, which this bill helps. The opioid bill helps do.
Absolutely. Yeah.
Yeah, yeah. So I appreciate you making that that connection. Okay, so we're running out of our time. We said we would be 30 minutes, and we want to keep these cup of joes to 30 minutes. But if we could, Senator, I'd love to pivot to primary care. Um, you know, probably better than anybody in the legislature, um, the crisis we're experiencing in primary care. The Senate president spoke to this in her opening remarks. I was super grateful, honestly. And you know that Western Mass, we have a pretty significant primary care shortage, and the practices in the region are struggling with workforce issues, reimbursement rates, and the overall stressors of doing business as an independent primary care provider. Some have affiliated with larger systems, but the ones who remain independent are particularly stressed and having a really hard time. And could you just talk to us, you know, for the last couple of minutes about the primary care work you hope that we advance this session?
Sure. So I think there's a couple, maybe three off the top of my head that I think we need to focus on. So the first one is where primary care falls in the hierarchy of what we spend.
Right.
We spend the least on primary care. They get,
Which is bananas, right? Because it's preventative care, it's
yeah,
upstream.
it doesn't make any sense, but we spend the least, okay? They are not their rates often, you know, in the community health centers, insurance, commercial insurance doesn't even pay what Medicaid pays for primary care visit. So they're paid very low on the scale. Now, for a lot of people, that's not why they're doing primary care. They're doing it because it is one of the most exciting and important aspects of care. It could, if we did it correctly, change the whole trajectory of health for many people, because they would be getting care that they needed early on when they needed, and it would be also preventative. But we don't do that. We value the specialists, we value the hospitals, don't value, we say we value the primary care, but we don't. So that's the first issue. The second issue is that the administrative burden is so profound. So that is all the electronic health records, all of the write-ups, all of the coding that you come in, you have a strep throat. What I have to, as the doctor, go through to make sure that I get paid for that strep throat, get paid for that visit, is extraordinary. Prior auth, many people have heard of it, where I have to get an okay from an insurance company in order to deliver you a treatment or a medication, spends, on average, I think it's now up to 2 or 3 full-time equivalent employees to do that work, just to get the insurance company to do what I believe they should be doing, which is paying for the service. We also pay fee for service. So a doctor gets paid every time you come in, or every time they perform some kind of treatment or service. And if you're owned by a private equity firm, or even a for-profit like United Healthcare, they want to make sure you see as many patients as possible as fast as you can. So not only are you burdened by the low rates that you get, you're burdened by how much administrivia you have to deal with, all the work you have to go through for just to get paid through prior auth, where someone else is telling you how you should deliver healthcare. And you're being overseen pretty dramatically to make sure that you get as many people in there as possible. So that's the second piece of it. And then the third piece that feeds into that, and this is what you all have been looking at, is if I'm going to get paid lower than any other doc, and I'm going to have to do all of this administrative stuff, I can't afford a $300,000 debt because I am never going to get out of that debt. And that's about the average of what it costs for me to go to medical school. So if I don't get some kind of relief from that, I can't even begin to do primary care. And so many people are making that decision for simply, it's not that they don't want to, it's that they can't afford it. So those, I think, three pieces are doing such, they are wreaking such havoc on primary care. We're losing primary care. I mean, the numbers are out there. The slots are open for medical school for people who want to go into primary care. And it's just become a crisis. And we ignore it at our own peril. The one last thing I'll say is hospitals are structured to fill beds. And so every time you try and take money from one group in the healthcare system and send it to another. So in this case, our most expensive treatment, not medicines and stuff, but is in hospital because those people are very sick and that's where acute care needs to happen. But if I try and reduce those costs, then the hospital doesn't, and I take that money and give it to primary care, the hospital's now in jeopardy because they're not filling beds. So they're now in a financial whirlwind because now they're losing money. They can't cover the costs of the people. So we have a system that just doesn't work. And it will take an enormous amount of change in order for that to really to fix itself. And that's what we have to do is we've got to start really um, moving the money. And that means we have to look at how many hospitals do we have? Do we need all these hospitals? Where is the primary care? And so one of the things that the market oversight bill did was it said we have to do a complete inventory down to the doctor, down to the nurse practitioner of who does what work there. And I know we're out of time. I'm sorry, I didn't mean to talk so long.
Oh no, my God. I think there are many people who watched this entire thing and wanted to really hear, especially that last piece, and just hear someone like you, frankly, um, go deep on it. And I do think you've just brought out in that last bit the tension, right, between hospitals needing to stay afloat,
Right,
and wanting to take money and treat patients in the hospital because that's where they make
right.
the bulk of their money. And yet many of them have primary care practices. And when we ask them, hey, come on over here, let's focus on primary care, it can be very financially challenging. And
Exactly. Yeah.
this is the bigger, we're not going to talk about this today, but right, this is the bigger issue we face,
Right.
with a system, um, a system that is driven so much by scarcity and profit and not enough, you
Right.
know, from that lens of affordable healthcare for all. So I really appreciate you so much. I learned a great deal. I'm sure folks learned a really good deal, amazing. Um, and so this is all the time we have. Really, thank you so much, Senator, for joining. Thanks to everybody who tuned in. As I mentioned at the top of this half hour, this is the first, but it's not going to be the last conversation we have with thought leaders in the Commonwealth. You please, everybody who's tuning in, send your ideas on topics you'd like us to cover, folks you'd like us to talk to, the questions that you have, the feedback that you'd like to give us. We're going to try to do these once a month. Thanks to Caitlin for leading. Thank goodness she's good at this. And again, a real big appreciation to Senator Friedman for kicking this off and for all you do in the legislature.
Well, right back at you. Such a pleasure and honor to work with you.
Take good care. I'll probably talk to you later today.
Sooner
Wonderful.
than he's here, right?
All right. Bye, friends.
Bye.